right. Well, good morning, good afternoon, good evening to everyone. My name is Ozge. I am a research faculty at the Silver School and also a senior research scientist at McSilver Institute. I'm also a co-I for our Achieve Training Grant. And today we have the privilege of hosting three of our achievers from sub-Saharan Africa that I would like to introduce to you briefly, and then we'll hear about the wonderful work that they're doing. Okay, so our first speaker will be Dr. Hawa, who is a consultant gynecologist and a senior lecturer at the School of Medicine at University for Development Studies in Ghana. Her research involves enhancing access to cervical cancer screening among women living with HIV in the northern region of Ghana via a participatory focused approach. She is passionate about women's health and champions extensive cervical cancer campaigns in the northern part of the country. Dr. Hawa is a key figure in the region's expansion of cervical cancer screening training program for midwives and nurses by MPath at the University for Development Studies and the Teaching Hospital. Dr. Hawa holds a fellowship with the Ghana College of Physicians and Surgeons and devotes time as a mentor to young physicians. Next, we have Dr. Nelson, who is a research associate at the Child Health and Development Center in the College of Health Sciences at Makerere University. He's an early career research scientist and a certified medical officer with clinical experience in the Ugandan healthcare system. He's deeply passionate about child health and infectious diseases, particularly malaria. Working in high transmission malaria zones, Dr. Nelson has encountered high infection rates among children under 5 years old and seen preventable deaths due to delays in care and limited health facility capacity. This has motivated him to pursue locally feasible interventions that can contribute to Uganda's ongoing malaria control efforts. These experiences have driven his interest in intervention studies that can create lasting community impact. And last but not least, we have Dr. Gideon, who is a lecturer, researcher, and field epidemiologist at the Fred Binka School of Public Health, University of Health and Allied Sciences in Ghana. He has extensive training and experience in disease surveillance, outbreak response, and public health research. Trained through the regional WHO Implementation Research Program at the University of Ghana School of Public Health, Dr. Gideon serves as a mentor for the Global Mentorship Scheme and the Ghana Field Epidemiology and Laboratory Training Program. He was the foundational head of the Epidemiology and Biostatistics Department at the Fred Binka School of Public Health and has led curriculum development for key public health programs while coordinating several school-wide initiatives. Please welcome all of our trainees, and we will start with Dr. Hawa. There's the single.
Thank you very much, Dr. Ozge, for the introduction. Good morning, good afternoon, and good evening, everybody. My project is on enhancing access to cervical cancer screening among women living with HIV/AIDS in the northern region of Ghana through a participatory focused approach. Now, in most countries in the developed part of the world, cervical cancer is way down the line when you talk about cancers among women. However, in low middle income countries such as Ghana, it is still a major problem. In Ghana, with a population of about 31 million, we have cervical cancer as the second leading cause of cancer amongst women, breast cancer being the first. And this is because all the preventive measures that are well known and tested are not being implemented as they are supposed to be. It's just recently in 2025 that Ghana started vaccinating its young girls against HPV, when other countries have more than 40 years of experience with about 90% coverage. Being its first time, we've experienced very low uptake of the vaccine, and parents are very hesitant to let the adolescent girls go and take the vaccine. The second tier of prevention that is also well known is screening. And screening for cervical cancer through either VIA, pap smear, or HPV is done in most countries. But in Ghana, only about 2 to 3% of women screen for cervical cancer. And with this kind of gloomy picture, it is not surprising to see that annually we record about 3,000 cases of cervical cancer. And because of late reporting to the hospital, most of these women end up dying. We record close to 1,800 deaths among women who are diagnosed with cervical cancer in a year. If we narrow the lens to the most vulnerable population of women who are exposed to the HPV, women who have any immunosuppression, like women living with HIV or female sex workers, for instance, their risk is higher. So women living with HIV have about 6 times the risk of developing cervical cancer in their lifetimes. So if this risk is this high, and yet screening amongst women is just about 2 to 3%, then we can imagine the burden of cervical cancer amongst women who have HIV/AIDS in Ghana. So the aim of my study is to assess the barriers and facilitators to cervical cancer screening, and then to evaluate whether a tailored 3R communication strategy improves awareness and knowledge towards promoting screening uptake among women living with HIV/AIDS in Ghana. For this, we'll be doing it through 4 objectives. The first objective is to identify the facilitators and barriers. And then after we do this, we would co-design a context-specific strategies with women living with HIV/AIDS that can fit within the HIV/AIDS care that we have within the country. And then we would implement it through a tailored 3R communication strategy. So for my work, I want to use communication as a way of reaching out to these women to increase their knowledge and awareness. And then at the end of the day, evaluate any changes in awareness and knowledge, and also the strategy that has been used. So the study is going to be a quasi-experimental study. It will combine both qualitative exploration and pre and post intervention quantitative study assessment. So for the qualitative part, we'll be conducting in-depth interviews with women who have HIV/AIDS, who have ever screened for cervical cancer, and those who have never screened for cervical cancer, to elicit what enhanced their behavior to go and screen, and for those who never screened, what the barriers are. And then through this, we would also have focus group discussions, and then use the outcome of the IDIs to fashion out the messages that we'll be sending in the phase 2 of the study. A phase 2 would be quantitative. So first, there'll be a background pre-intervention interview of both the control arm and then the study arm. The study arm will receive the messages after the background interviews have been done. Then along the line, they would be reassessed again. Both groups will be reassessed on their knowledge. For the control arm, they would receive their normal HIV/AIDS care as per the clinic's protocol. So far, what has been done, I have successfully, through my mentors, been able to get my protocol sent for IRB clearance. And I've also received administrative clearance from both facilities where I'll be doing the study. and we have started with the in-depth interviews. Currently, the in-depth interviews are still ongoing, and we are also transcribing the interviews from the local language into English, which takes really a long, long time. And we've started recruitment for the second phase. So for the next steps, I'm looking at the focus group discussions when I go back home, and then to launch the phase 2 and start the analysis. So what are the next steps for me so far as Achieve is concerned? I'm looking forward to, after this pilot project, to at least publish 2 papers from this work. Also, to give me the ground footing to apply for a grant so that I can do something bigger and escalate this. And also at the end of the day, with a larger sample, I'll be able to assess whether uptake is actually improved by the work that has been done. I am looking forward to more collaborations and more research opportunities in the area of women's health. Thank you so much to my mentors, Dr. Juan Yen. It's been very lovely. Dr. Yeshim, she's spent so much time with us. I know she's somewhere online. And oh, sorry. Prof Kenu and then Prof Tope in Ghana, they've helped so much in the formation of the proposal when I started. And for our chief team, Anna, Chelsea, Felisa, who is here with us, and Bethel, we couldn't have come this far without you. We are really grateful for all the steps that you try to walk us through the right path, and we appreciate it all. Thank you very much.
We'll do the questions at the end. Yeah.
Next. Just click next.
Click next.
Next.
Yeah.
There's the arrow.
Good morning, everyone, and good afternoon, good evening for those who are outside the US. So my name is Nelson Ssewante, as I've been introduced, and I'll be talking to you about my project.
Sorry.
So
There's something on the screen.
That's not
sorry about that. So my project is titled Development and Pilot Testing of a Digital Algorithm for Management of Childhood Febrile Illnesses in Uganda. So just to give you a little bit of the context about Uganda. So Uganda, I don't know what's happening. Can I use this? Yeah. So Uganda is a small country found in East Africa, and it has a population of about 48 million people. It operates as a decentralized healthcare system with tiered centers, if you can say. We start from health center, from village health teams. These are people in the community who volunteer to participate in diagnosis and management of children. Then the system runs all the way to the national referral centers, and we follow that referral path. You realize that about 66% of the OPD cases are seen between Health Center 2 and Health Center 3s. So these are centers which basically have nurses, clinical officers, and midwives who see patient, make diagnosis, and treat. So the system heavily relies on out of pocket expenditure and donor funding with very limited insurance coverage. Uganda does not have public health insurance. And according to the statistics from the Ministry of Health, just less than 5% of Ugandans have any sort of insurance. And UBOS also shows that 16% of Ugandans live below absolute poverty line, that is spending $1 per person per day. So we also have challenges about workforce. So we have a shortage, is also underfunding, as I've said, and we have an issue of underdeveloped referral system with very few ambulances. And with that, we also see that about 25% of Ugandans live more than 5 kilometers away from the nearest health unit. So with that knowledge, we also know that fever is the leading cause of OPD visits, especially among children below 5 years. And fever is commonly caused by very many infectious diseases, including malaria, respiratory tract infections, and diarrheal diseases. Now, through the previous projects, in the past couple of years, I've participated in a research study which was looking at the accuracy of reporting of malaria RDTs by clinicians at lower level health facilities 2 and 3. And during that study, I made an observation where we found that about 7% of RDTs carried out at these centers were actually falsely recorded as positive when they are negative. And when we went deep to understand why this happens, clinicians told us that because patients present with fever and yet the only test they have is a rapid diagnostic test, and then based on their training, they're usually limited in making alternative diagnoses. Then they are forced to make to alter RDT results to justify provision of antimalarials. So with that, I thought it would be important to suggest mechanisms or strategies to improve their ability to make accurate diagnosis and management plans. So there have been a few supportive systems or tools to guide in this approach. And one of them is the IMCI, which is a guidelines from WHO. And then in Uganda, we also have what we call Uganda Clinical Guidelines, which is adopted from IMCI, but also it is paper-based version as IMCI. So because it is a paper-based version, because those two tools are paper-based versions, it is the major challenge we face is low uptake. Because as you've seen, these centers have high volume, they have a high load of patients. And so using guidelines that are paper-based is usually challenging. So I'm suggesting this study with the following objectives. Number one is to develop a simplified digital algorithm, which is termed FEBRIS. FEBRIS is Fever Evaluation Based Response System, integrated system. So this is going to be put on the phone or a tablet, and then it will guide through the diagnosis to management. So then the second objective will be to assess the feasibility and acceptability of this algorithm. And then the third will be to assess the level of concordance between healthcare workers' diagnostic and treatment decisions and those of a reference clinician at 2 selected health centers before and after introduction of this algorithm. So in methods, for objective number 1, we reviewed literature and drafted the algorithm. And then after that, we are currently working on digitizing this algorithm. We also looking at conducting consultations with policymakers in the area to make sure that we stick the local guidelines. And then the second objective, we shall use in-depth interviews. These will be among the clinicians at the selected health facilities. And we'll be looking at understanding whether this algorithm is something that can be feasibly implemented in the local context. And then we shall do a pilot evaluation just to see the effect of using this algorithm in this setting. We shall do 2 surveys, patient exit interviews. Each cycle will have about 100 patients. And we'll be looking at the level of agreement between the decisions made by clinicians at the center, and then with those that will be done by our study clinician, who will follow the national guidelines to make a diagnosis. And then we shall assess the agreement between those 2 decisions to see the impact of the algorithm. And that's it. I want to thank my mentors, the Achieve team, program implementers, and my mentees who have helped me in this work. Trust me, this is not exhaustive, but I hope everyone who has really helped us continue to do so, and we are also looking forward to inspire other people. Thank you so much.
Good morning once again, good afternoon and good evening to all online and those who are here. Thank you for the opportunity to present my work, and thank you to Dr. Ozge for the kind introduction. All right, so we've moved from cervical cancer and HIV in Ghana, malaria in Uganda, and we're back again in Ghana. Okay. And you're still looking at HIV, but this time amongst 2 very vulnerable populations, mothers living with HIV and their infants. And so the Empower project focuses on improving HIV prevention from mother to child through a very real-time mHealth approach in the eastern region of Ghana. And we've come this far through the support of mentors who are in the University of Ghana, and also those here in NYU, Dr. Yeshim Tozan, and then Dr. Yen. So thanks to you once again for making it possible and bringing us this far. All right, so mother-to-child transmission of HIV remains a real major public health challenge in sub-Saharan Africa. Despite the availability of proven interventions, the prevention of mother-to-child transmission program and the early infant HIV diagnosis program are proven, and they have been able to eliminate mother-to-child transmission in many countries around the world. However, there are still some gaps that persist in sub-Saharan Africa, including Ghana. Now, only about a third of HIV-exposed infants actually receive diagnosis. And then for those who even test positive, only about 40% of them are initiated on ART. And the linkage to care for the pregnant women to receive ART to prevent mother-to-child transmission is just about 44% in Ghana. So clearly there is a huge gap, and a lot of infants born to mothers living with HIV are falling through the cracks. And these are the results. Also, clearly, it's not the lack of the interventions, but then system bottlenecks, which include delays in testing, the turnaround time in bringing results of HIV-exposed infants, for linkage to ART, even when the kids have tested positive for HIV, and then lost to follow-up. And in the past, digital health tools have been promising, but those that we have currently, they are passive in nature. They collect data, but they don't inform how we can take real-time action to be able to track each infant, to be able to bring them back into care. And so the Empower project is actually designed to integrate implementation science and mHealth so as to be able to strengthen the PMTCT-ID cascade, because there are a number of steps that mother and infants have to navigate to be able to get to the end of it, and it's always challenging. And so for the Empower project, it's structured around three main aims. The first one is to be able to conduct a thorough epidemiological analysis of routine data so that we can be able to identify system gaps and also look at the trends to see how it is performing. But beyond that, this will provide the empirical basis for us to be able to put in any intervention that can address this problem. But beyond that, we want to also put in a structured evaluation of the surveillance system. The clinical interventions, that is PMTCT and EID, they are supported by underlying surveillance systems and diagnostic systems. And therefore, we need to find out what the operational bottlenecks are to be able to address them and incorporate them into the mHealth application that we intend to design. And so the third objective, which is probably the most important, is to be able to use whatever information that we've had to co-design and implement the mHealth digital solution to reduce turnaround time and improve the retention of mother-infant pairs in EID care. And it has been structured in three main phases. So it integrates both quantitative and qualitative methods to be able to generate the quantitative evidence and also to give us a certain contextual understanding of the problem. And we are conducting this study in very robust implementation science principles as a result of the mentorship that we are receiving from our mentors. And the data sources for us to be able to undertake the first phase will include records in the facilities, surveillance reports, in-depth interviews of providers, frontline providers of early infant HIV diagnosis services, and then also focus groups discussions amongst the caregivers to be able to help in co-designing the mHealth app. And then the second phase will be when the mHealth app is implemented over a certain period of about 6 months. And then the third phase will be the underlying data collection, where we collect all the data to measure impact of the app. So the phase one has been largely done. It involves stakeholder engagement. So the picture you see on the top left is actually the program manager and the deputy manager of the National AIDS Control Program. And I'm the one on the extreme right. And next to me is my chief site mentor, Professor Yorson, who graciously accompanied me to see the managers. And the stakeholder engagements have gone through all the levels of the health system, from the national to the regional, the district, and to the specific study sites where we'll be conducting our studies. And those are the pictures showing the interactions and consultations that we've done so far. We've also interviewed caregivers. We've had focus group discussion with caregivers. We've had in-depth interviews with the frontline health workers who are involved in helping us to design this app. And this app is not going to be a parallel system. It's going to integrate with what we have already, just to alert us to know clearly, very visibly, the delays in the steps that are involved in EID. And so the phase two will be to co-create a real-time mHealth tracking system. And then the final phase will be to collect inline data across all the intervention and control sites to be able to measure the impact it's had on turnaround time, linkage to care, and loss to follow-up. And it's believed that we will generate some scalable evidence for improving child survival and contribute to the elimination targets in Ghana and even beyond Ghana. And we believe strongly that it has potential for broader implementation across similar settings in Ghana and across Ghana. All right, so I want to thank all those who have been involved. I mean, at CGH, there was a lot of talk about it takes a village to be able to bring up a scholar. And so a lot of people and institutions have been involved in bringing us this far. The PIs, Dr. Fred, Dr. Mary McKay, and Dr. Ozge, the program directors and managers and coordinators, Chelsea, Anna, Melissa, and then the amazing Achieve mentorship team that I have from the University of Ghana, and those in the NYU. Thank you very much. So those are some pictures that we've already, that's myself and Dr. Yen on the Brooklyn Bridge. Yes. And we've been to Joe's Pizza with Professor Dr. Yashim Tozan as well. So thank you very much for the opportunity.
Well, can we give our trainees one more round of applause? I hope you all have been as inspired as I was listening to the amazing work that our early stage investigators are launching through their Achieve Fellowship. I have some questions, but I would like to open it up to our audience before I go ahead and ask. Yes, if we can, as our guests of honor, please take a seat. Dr. Teresa.
Yes, thank you. This always blows my mind to see how amazing our Achieve Fellow and to see your brilliant scholarship. I had worked on the topic of HIV and AIDS earlier in my career, Gideon, as you and I spoke yesterday in Rwanda. And when prevention of mother-to-child transmission of HIV became a reality, it was a real game changer. And that's the one thing I wanted to learn a little bit more about in the context of Ghana. How much is PMTCT being accessed, and how is that failing too? Because now you're having to treat very preventable pediatric HIV. So I was hoping you could talk a little bit about the PMTCT dynamics too.
Thanks very much, Dr. Teresa, for coming and the question as well. So the problem is not access at all. Ghana has one of the highest antenatal coverages in sub-Saharan Africa. And then also even for the 6th week after delivery, immunization coverage is very high. So access is definitely not the problem. It's the middle gap where mother and infants have to navigate all these steps to be able to come back for test results. Sometimes they come 4 or 5 times and the test results are not ready because we would have to send the samples to the regional capital where there's PCR machine is. And so they come often and they don't get the results and they give up and never come. And sometimes the turnaround time is as long as 1 year. And it defeats the whole purpose of the early infant HIV diagnosis service. So the problem is definitely not the intervention, but that middle gap, system bottlenecks that prevent mothers from getting the results so that they can quickly make a decision as to initiate ART for those who test positive and also to keep those who test negative to remain negative until 18 months. And so that is the real challenge with Ghana. It's not access, but the middle gap. And that's where the study tries to target, to be able to make some real impact. Thank you.
So another hand over here.
Thank you. And really nice talks, everyone. I have another Ghana specific question. I've heard that prevalence of HIV in Ghana is very low. And so I don't know how that impacts your work in terms of, it's a smaller population. I don't know if there are issues of stigma or other barriers because it is kind of not as prevalent there as it is in other parts, Southern and Eastern Africa. Oh.
Very right. Ghana has a generalized HIV epidemic, and the prevalence is usually between 1.8 to about 2.2 if it goes that high. But then there are key populations. So for MSMs, it can go as high as 15%. And then for long distance truck drivers and all of that. So there are key populations that are driving the epidemic. And for certain regions also, these are hotspots, especially in the eastern region of Ghana. Consistently, it's been above the national prevalence. And sometimes it goes as high as 6%, and whilst the national is around 1.5, due to several factors that have been studied extensively. And so that is where the focus is, trying to reduce the burden so that we can be able to reduce it to the level of the national. And so that is what I can say for now. I don't know whether.
So, yeah, thank you very much for your question. Usually when we talk about prevalence and we get the percentages, you lose sight of the absolute numbers. So though we have 1.7, what does that 1.7 translate to? Translate into so many women, and we have higher numbers of women having the HIV. It translates to so many women who are going to die early and leave their babies. So it really is not a matter of what the figure is, but then what's the impact on an already struggling socioeconomic situation. I was surprised myself when I started going to the clinic to get my participants to do the interviews. And within a week, I had my 64 already. Within a week, one clinic in just my teaching hospital, just one clinic. So the percentages are absolute. Maybe elsewhere they may say 34%, but what's the population? We are 31 million. 1.7 is still a good number. Thank you.
Are you done? Question?
Thanks again. So on Uganda, when I was at the Harvard School of Public Health, we had a faculty member named Dr. Mark Mitchell. And I don't know if you came across Mark's work with the organization D-Tree, digitizing IMCI. And because I'm guessing they already have a fever module. So I just want to make sure that you don't, you build from what's there without duplicating and then take it further. So could you talk about, have you found Mark Mitchell's research, D-Tree, IMCI, digital tools? Because they're pretty scaled up. I just wanted to hear a little bit more because I know you did a lit review.
Yeah, thank you so much, Professor Teresa. I've come across D-Tree, though I didn't know nature. And I've also looked at other electronic digital algorithms like Almanach, which was implemented in the context of Tanzania and other countries. What I've actually used their frameworks here and there to design mine. But the reason why I thought a new one would be important is the fact that all these algorithms have been trying to use IMCI framework, but I feel like they are not well contextualized. For example, the issue is whenever a patient comes and these people do an RDT, if it turns out positive, they forget about other things and they treat malaria. If it is negative, that's when they start thinking about other things. Now, I didn't project what I've designed, but I'm trying to make sure that we first forget about malaria, ask the presentation, and then we can treat. We can do the test and interpret on the background of the presentation. So there is a little bit of a change. Yeah. So to make mine a little bit different and contextualized in our settings. Thank you.
Any other questions? Any other part of sub-Saharan Africa? You're back to James.
But you had to get a little more countries up here and then we'll do it.
Miles, do we have questions in the chat?
It's just commendation.
Okay. So I have a question. Could you tell us a little bit about how Achieve training program has facilitated some of these research and career goals that you have been aspiring to achieve?
Okay, so I'll begin with that. So Achieve has really been transformative, I would say, because I've had some training in implementation science in Ghana, because I trained for my doctoral degree in the WHO TDR regional training site. But as I've told my colleagues and my mentors already, I felt it was not in-depth enough. And so the frameworks, the methodologies, the designs, those robust parts of implementation science, I felt there was a need to learn more. And so once I got the opportunity and I saw the link, I said, this is an opportunity for me. And so for that side, it's been, since we've been here in 3 weeks, we've had intense mentor meetings with Professor Yeshim. And I remember 2 days ago, she actually showed the whole process of having inputs, activity, and then the reach, and then the outcomes, all of it's clearly trying to break down all how an intervention study should look like. And so it's really informed our work and refined our work to a certain level that we can actually call ourselves implementation scientists as well. And so for me, it's been really transformative. Yes, thank you.
So my experience is not so different. I'm an early career researcher. This is probably my first big project. I got lucky to actually realize that Achieve is a well-planned program, which gives intensive training in implementation science and data science. And then this really gave me grounding in understanding the concepts of implementation science. But also importantly is that as an early career researcher, I usually need to expand my network, and Achieve has been excellent at providing that platform. Naturally, I'm introverted. This is really a good way to network with people who have experience in research, but also can connect me to the next person who is interested in my research area. So yeah.
So, my story is similar. And I should say the first time I was introduced to Achieve, and my Sasha here was the one who told me about Achieve and said, oh, you come around, I'll help you get something. I hadn't heard anything about implementation science. I didn't know what it was about. So I had to go and read. My first attempt didn't go well. I nearly gave up. She said, don't give up, let's go again. And in between time, I took the effort to enroll in some online programs that were doing introduction to implementation science, just to give me that understanding what the whole thing was about. And joining Achieve, it has been amplified, because then we had all the sessions that we had, I get to understand it even better because I have some background and now it's being built upon. And I must say that it's a new chapter. I've been a clinical person and this is a new chapter for me and I'm enjoying it. And I'm hoping that this is going to open up a great research chat for me to follow. I have so many young OBGYNs back at home, and I'm ready to pull them along so that we get a bigger team that can do things back at home.
I was hoping that would start a new wave of questions.
Well, I'm going to try to hit everyone's presentations in one question and try to get a little bit more of the context that you know so well so that we can learn more from you. But I'm delighted to be on this journey with you all. And thank you so much for the wonderful presentation. So my question is about sustainability. You all are working some innovative solutions with the knowledge of the context, but there are still challenges. So I wanted to ask you, what are 1 or 2 important barriers that you'd see with the solutions that you're proposing to some of the most challenging and persisting public health issues that we are observing in Ghana and Uganda?
Thank you. Amazing, Yeshim. All right. So clearly, we have to think about sustainability. It is not driven by the whole study that has been designed is driven by the problem that exists. And so in our interview of the frontline health workers, we looked at issues of overburdening them with a lot more to do. They're already overwhelmed with work. So what system can be integrated into whatever they have so that it does not look like more work? So those are the questions we asked them. And so it's a simple tracking tool that mimics exactly what they do. And it's going to integrate with what we call the E-Tracker. The E-Tracker in Ghana was designed to be able to track HIV clients wherever they find themselves, because due to stigma issues, they traveled long distances so that they are not known, especially those who are opinion leaders, teachers, and others don't want to be seen or known for their status. So they will travel long distances, 2 hours away. And it was a problem for the program because then they begin like new patients. So the E-Tracker has really helped with that so that wherever they find themselves, they're able to continue with care. But it's become passive over the period. And so this one will not run a parallel system, but sit with it just to make sure that every delay along the step is visible and actionable. And so it turns more into an active app that helps to improve the system so that no child is missed along the cascade. So that is how I hope it can become sustainable, because adoption is the biggest risk. If they don't use it, then that is a waste of time for everyone. Yes.
So what I see as a potential barrier is going to be access to a mobile phone. This is a digital platform, and there have been questions of whether actually clinicians at this level have a smartphone. One of the other reasons why I chose that region, Soga, is that I have a colleague who is interested in digital innovations and recently conducted a survey among healthcare workers at that level 2, level 3, up to level 4. And he was looking at smartphone ownership. Actually found that over 80% of clinicians at that level own a smartphone. But of course, there is the other percentage who doesn't. So I think one of the aspects that I have to look at in improving sustainability is being in touch with policy implementers. First of all, if we show that this algorithm works, then they are the best people to see, at least even if each clinic has one tablet that is dedicated to that clinic, maybe all people who access the clinic and work there can use it to navigate through patient care. That will be the gist of improving this.
Thank you very much. The end game for my research is to see improvement in the uptake of cervical cancer screening. However, there are so many challenges. Looking at the knowledge and awareness is just one part of it. This is the side of the women themselves. But then there is a bigger part of it that is not related to them. It is related to the system. Just like I said, it's just last year we started HPV vaccination as a country. Screening for cervical cancer is out of the pocket in Ghana. We have a national health insurance system that doesn't recognize this as an essential service. There is still strong advocacy going on, and it's the strong advocacy that got us to get the vaccine. And we've not stopped. We have so many women's groups, including Medical Women's Association of Ghana, of which I am part, and I'm always talking about the cervical cancer part. So it is our aim to get the VIA covered by the NHIS system, so that it takes away the aspect of having to pay. If finally the woman is aware and she wants to go and screen, there shouldn't be another barrier that would say that you can't screen because you have to pay. It is just about $6 for VIA in Ghana, but that is catastrophic amount for most homes. A woman can be there in the whole 365 days of the year and cannot have her own $2, just free $2 that doesn't have anything to do. So it is quite, so that's what we are pushing for. And for me, I see that is the part that would put everything together, if we're able to get the NHIS to cover screening, then we increase awareness. If this works out and we scale up, then you know that more women are going to have the information and they are going to come. And when they come, the doors will not be closed. They will be open. There is another aspect in between that. So in between that is the providers. And Ampad Ghana, which is also from NYU, we are bridging that gap in Northern Ghana. We're training midwives and nurses in providing cervical cancer screening in a modular fashion. We've done 4 cohorts and they are doing very well. Hopefully, Ghana Health Service would take this up so that when the project slows down, it doesn't die off, because now we have local capacity to continue the training so that all the areas will be covered and then uptake will increase.
Any other questions?
But I have one that applies to everybody. Okay, same thing. A question that applies to all 3 of you. Could you talk about how you see AI fitting into the work you're doing? You know, both positive and negative. What is the potential role of AI? And then I have the same issue, Hawa, as the slowdown with translating lots of qual data from, you know, local languages. But some are in Google Translate, including Kinyarwanda now. So has anyone used any of those tools to translate local languages? There are IRB and HIPAA sort of protection issues to think about. But I'd love to hear if anyone's gone there, because I wonder if it couldn't help us speed up if we can do so ethically and following all the IRB protocols.
All righty. So AI is certainly a game changer. I was teaching my students and I showed them the library of Harvard University, for example, and it's bigger than the whole university. So there was a huge gap in even accessing materials for the kind of courses that they do. But then AI has closed that gap a bit. Now you have access to whatever your colleagues in Harvard are doing. You can actually access their lectures and all of that. So AI is certainly something that's even going to have more impact in sub-Saharan Africa than even here, I believe. And I can see that there's a lot of interest here. Only yesterday, Dr. Yen got us in her office for 1 hour trying to show us the AI tools that can help with teaching, with research, and all of that. And she's already shared lots of links with us to be able to be part of machine learning and all of that, because she recognizes how helpful they've been to her. And so yesterday we discussed chatbot and so some of our projects. How can we incorporate AI to be able to speak to, let's say, the mothers, for example, to provide automatic responses to the mothers, that your results is ready. Can you come to the hospital? And then she responds and say, I've traveled for 2 weeks. I wouldn't be able to come. AI should be able to respond and say, okay, no problem. We can fix this date for you and all of that. So clearly there are many, many pathways that we can incorporate AI into our work. And we are learning very well. We're learning very quickly to incorporate that. Thank you.
So yeah, probably a similar response. One of the area where AI can be integrated in my system is trying to reduce the time of interaction between the clinician and the patient. So if we can reduce that gap, because like I mentioned, the issue we have is that these are small clinics, but have huge numbers of patients. You go at a health center too, for example, and each day they see about 50 patients, and there's only one clinician around. And then sometimes you find that because there's only one clinician, support staff, cleaners, security guards are going to come in and help. So if we can integrate AI at that level of clinical evaluation, maybe you can speed up that work and make the system stronger. Then the other aspect that we need to look at is trying to integrate this system into the electronic medical records to try to bridge the gap between trying to register in a paper-based version and then they capture information from the paper to the system again. If you can just bridge that gap, maybe the system will be even more accepted within the policy frameworks. Thank you.
In the area of cervical cancer, AI is already doing a lot with the diagnosis when it comes to doing the VIA. Some programs have come up that you can remotely do the VIA, take the pictures, upload it onto the system, and the AI has been populated with so many images, so it can give you a suggestion whether this is a suspicious service and all that. So those systems are available. In my work in particular, AI can also come in if it is integrated into the HIV care setting, so that women along the way we get to know that this person is due for a cervical cancer screening. And then we have some messages like I'm trying to develop. These messages can be automatically sent as reminders, and then they can come in. And then if the facilities do not have high-ranking people, then what I've just described can also come in, so that there are linkages between the satellite hospitals and then the bigger centers where we have highly trained midwives and doctors, so that they can collaborate and have diagnosis properly made and treatment given.
About the link.
So the language I haven't come across, honestly, I would love it if there's anything that can translate from the Burnley straight to English. So I would take the name of and then I'll go and search whether my language is there.
That could be a good achievement
Yes.
module. Just because I think it's emerging in a lot of African languages now. You can
Okay.
a lot of African languages. It uses the nearest neighbors, like Swahili, if it's related, or if it's a Bantu language. So I think Achieve should look into this because there's ethics issues.
Yeah.
You have to get permission, you have to get IRB clearance, but it's worth us all investing in finding out.
Huge time savings.
Yeah.
It's a time and money saver. If you could do it, you got to check it. You don't trust it.
Yeah.
But you've got at least the first pass could be sped up if we can do it ethically.
Okay. That's all. And then I'm gonna thank our achievers one more time. And thank you all for being here. Thank you for presenting and letting us hear about all the wonderful work that you guys are doing. Thank you.